reprimanding. So I do have to correct that I'm no longer with the university. So in July, I started my own practice after 20 years of being at the university. So I'm launching my own thing nowadays. So I do want to start, anytime I start with a talk around sexual health, I always make a comment about how I want this to feel like a really great sexual exchange. Meaning, my needs will be part of the experience, and your needs shall be part of the experience. So I really am open to questions as we go or at the end. I know we have a really truncated amount of time today, so because of that, we may want to, you'll find me as the day goes on, or catch me at the reception tonight, something like that. I really am interested in, though, you leaving this conference without having questions around the sexual health and recovery piece. Okay, so this number, 100%, that's a really big number. That's like everybody, right? So 100% of people who are diagnosed with cancer have some impact to their sexual health and well-being. So that means there's a big spectrum of what that means. That means they may have a lower libido. It means they may have pain with intercourse. It may mean some of our men can't develop erections. It may mean difference in risk-taking behaviors. It means a lot of different things. But as providers, we have to keep in mind every single patient that you are dealing with that has a diagnosis will have an impact to their sexual well-being. And I'll note that's not just cancer diagnosis. That does also include other big medical diagnoses like MS, Parkinson's, some of the biggies that you might think about that are life-altering. The interesting thing about this number, 100%, is that it doesn't matter what the prognosis is. We still have a 100% impact, right? Wow. So someone with melanoma who has a mole, we're going to remove that little dude, it's done. It still alters their sexual health and well-being. The reason we think about that from a psychological perspective, like why would such an easy mole removal still change if we have libido or not? It changes our sense of self. It changes our sense of self because cancer impacts almost every aspect of who we are as a human. It changes us financially. If all of a sudden we're trying to scrape together money, how are we going to do this? How are we going to pay for the treatment that has to be done? It changes us soulfully or spiritually. It maybe makes us question our God. It maybe makes us reject our God. If we aren't connected to a God, but nature is our spiritual space, maybe we can't get out and move the way that we used to, so we can't have that solace. However we think about spirituality, it's going to be shifted and changed, right? It changes us relationally. So our partner may be now the person who, I can tell you when my own husband went through cancer treatment, I was the person who was cleaning up his diarrhea, literally, right? I did not feel like sexy time at that point, right? So it changes us relationally. And when we see that caregiver and patient dynamic, it almost feels more like a parent-child dynamic. It's taboo to want to be in a sexual relation with a child, right? So it shuts us down. It's almost like a volume goes down to zero around sexuality. Okay. The other thing we need to consider is also our partners are impacted. It's not just impact to patient, it's impact to partner or partners, whatever their dynamic is. It doesn't matter if that's long-term partner or short-term partner. I absolutely have people come into my office to say, gosh, I had been hooking up with this person a couple times, and then I told them I had a cancer diagnosis, and they ghosted me. They disappeared. Right? If we think about those long-term partners, though, there's a lot that goes on for the long-term partner. There's a secondary trauma that they are then navigating. Again, we talked about that role, that patient caregiver role, that has shifted. So that's something that's being navigated. I have a lot of people that come into my office and they will talk about a couple different ways. It's kind of on the opposite ends of the spectrum. Some people come in and say, this cancer diagnosis makes me afraid that my partner is going to die. And my reaction to that is either, I need to shield myself and hide from them, because if they die, I have to preserve something within my own being so that I can keep standing. Or they might die, I need to eat them up for breakfast, lunch, and dinner, because when they're gone, they're gone. Right? So we kind of see this big shift, one way or the other. Right? One of the biggest things that I see is a tremendous lack of confidence when we talk specifically about that sexual recovery and sexual healing. So if a patient doesn't know who they are anymore, because maybe they've gained weight with their treatment, maybe they've lost weight with their treatment. I certainly have people come to my office and say they feel like they have a little boy body now because they're so thin and they don't have hips anymore, right? That type of response I get on a regular basis, but they don't know who they are. They don't know who they are soulfully, physically, they don't know who they are energetically. They don't know who they are. They don't know how to have their own orgasms with or without that fabulous vibrator they have. They still can't reach their peaks. And now we're going to ask their partner to figure it out. Like they're supposed to have the answers. It's not even their body. So that lack of confidence is one of the most huge barriers that I see for both partners and patients. I see heads shaking like that is making sense to everybody. So luckily in my world of sex therapy, there are things that we can do to help both people learn to navigate these new territories and feel incredibly competent in being erotic partners once again. Okay, so I'm just giving you a few. I'm giving you like a preview. So every single person that comes into my office and has a sexual concern, I see them as a thumbprint. And when they're coupled, now we got thumbprints smashed in together. So it's a really crazy looking thumbprint. But I'm just, like I said, I'm going to give you a few ideas on how we might navigate this from a sex therapist perspective. Okay. So one thing that we often do is we change thoughts about self. So if somebody comes in and they say to me, after my mastectomy, my 4-year-old came to the hospital to see me and asked me if I was still a woman. We're going to change some thoughts around that, right? Sometimes people say, I'm broken. I'm broken. So again, if you think about, do you want to invite someone into a broken space? The answer is almost always no. We're going to challenge some of those thoughts. We're going to create some new truths. If any of you have heard of cognitive behavior therapy, and maybe somewhere along your massive education you've heard those terms, sometimes people think cognitive behavior therapy means we're just going to think Pollyannish thoughts. Right? That's not effective. Cognitive behavior therapy is really about finding those new truths. And I really say truth intentionally, right? Not something happy. Something real. Something real we can anchor in that's not unbroken. Okay. Another thing we need to do is change the sexual narratives. So this is similar to changing our thoughts, but different in that we get handed, all of us in this room have been handed a sexual narrative that says something like, in order to be sexual, that means there has to be something that enters some hole. Right? There needs to be some kind of a penis and vagina narrative in those heteronormative relationships. It needs to last for this long. There needs to be an orgasm that's reached as an end result. That is horse manure. Even if you look at research related to what the brain is doing around sexual touch, if we lay close to our partner and have skin-on-skin contact, the same pathways in our brain are activated. And then if there's thrusting, woo-woo, hanging from the chandelier kind of stuff going on, right? When we are showering with our partner and they're washing our hair in a lovely way, same pathways, right? So we need to start to shift how we think about sexual connection and intimacy and what that really is. What does it actually involve? What does it mean for us? Why are we doing it? What is the goal? Is the goal around connection? Is the goal around closeness? I say to all my clients, like, if you're not doing it with the checkout person at Target, we can call it sex, right? It's some kind of sexual or intimate exchange. And then that allows us to open up and move back towards pleasure again. There actually is a really lovely podcast. I hope you all are listening to podcasts the way I listen to podcasts. I love them. I love to take knowledge in every day. There's a really lovely one. So it's called, speaking of sex with the pleasure mechanics, they have like 400 and some episodes. If you want to really stretch who you are as a sexual being, you can listen to all 400 and some. But there is one where they looked at sexual health and well-being related to chronic pain and illness. And in the episode, one person had a traumatic brain injury and had to figure out how to recover erotically after that. And the other person who was being interviewed woke up with an autoimmune flare that left them unable to even lift their arms with so much pain. There's a lesbian woman whose wife had to help her navigate. And sure enough, in that episode, they do this really great path. They show you the mental, emotional path to move back towards finding pleasure. And the question they ask, which I think is such a beautiful question, is what pleasure am I capable of now? Right? So when someone is having diarrhea, I'm thinking about that side that was just up with diarrhea and fatigue and all those different side effects and symptoms, you may not be capable of a lot, but what pleasure am I capable of now? That's a great way to open those doors. The next thing that becomes really important is anytime we think about sexual recovery, in the world of medical trauma like this, we're actually doing trauma recovery. So if your body is holding the trauma, we have to use your body to recover from the trauma. So we could talk all day long about how you're not broken, about how your body's capable of pleasure, about how we can build new confidence, about all this. We could talk and talk and talk and talk and talk. And then patients will go home and they won't touch each other, right? That's all they'll do is talk. So we have to use the body to heal because we have to teach those pathways that were traumatized that now we're okay and we're safe. So those neurological pathways have to be shifted back into safety, okay? We can't talk that out. So instead, we'll do exercises like, sometimes I'll start with a non-erotic touch. So I'll ask couples to do something like a scalp massage or a hand massage or a foot massage, whatever. They can pick whatever. Elbow massage, I don't care. Just something that doesn't feel very erotic. And while they're doing that massage, they have tasks to accomplish. They actually have to speak out loud. And by the way, if you are not a cancer survivor, try this at home anyway, because this is hard. We have not been given permission in our culture in the United States to be able to say, I want to be touched like this. Can you touch me more like that? Can you stop touching me there? Right? We don't have language. We have this narrative that's a BS narrative, and we need to be able to break it up. So try this at home, everybody, right? But this is really beneficial for our patients who've had these medical traumas. It teaches their partners how to touch their bodies again. It brings them back into their bodies if they've left the building and been floating up here throughout their entire diagnosis and recovery period, right? So I asked them to talk about how they want to be touched. Do they want that touch to shift? Do they want a lighter pressure, harder pressure? Do they want somebody to linger a little bit longer in one particular spot? Are they done with that touch? Do they need it to be over? Right? All these types of things are happening during the hand massage or scalp massage or whatever, wherever they're picking. Their partners then get to hear. They get to learn this new body because it is a new body. It is no longer the same body. It will never be the same body. So they get to build confidence. They also may have to come back into their body and into their being because of their own trauma. So we start with something like non-erotic touch. And then we expand from there. So if they started with a hand massage, I'll ask them if once that goes well, it never goes well the first time, by the way, never, ever, right? It may take 3 or 4 times before it goes well. Then where do you want to expand to next? And we just keep expanding until we get to the beautiful erogenous zones. Right? But by then we have the skill set to be able to say more or less, stop, pause, lubrication please, right? More, less, all of it. Okay. Any thoughts about that, questions? I'm seeing more heads nodding like you're getting it, so this is good. Okay, so there's a few more things I just want to cover, and then I see that I'm going to actually go ahead and jump to this next thing real quick. Again, catch me afterwards. I'm happy to answer 1,000 questions. Okay, on the way to Boston, like this trip to Boston, I was at the Kansas City airport. I get in my shuttle. There are these 2 elderly gentlemen. One was very gregarious, and he says to me, "You're going to Boston too?" I said, "Yeah." "Well, what are you going to do there?" I tell him what I'm going to do there. Why wouldn't I, right? So then his little old buddy says, "You can't recover from sex after cancer." And he said just like that. I'm mimicking him perfectly, right? Well, when in the airport, he goes to the bathroom, a little curmudgeon-y guy goes to the bathroom, and his friend goes, "He's an oncologist." Yeah, so then it made me think we better add this slide when I get to my hotel in Boston. We need to figure out as providers what keeps us from talking to our patients about sexual health and well-being. Because every website on the entire internet that's talking about sexual functioning and concerns says, if this is happening, talk to all of you, right? So if our providers aren't bringing it up, they don't have the skill set, they don't have the confidence, then we are in big trouble. So there is a worksheet that is, and I don't think I can click on it actually, but there's a worksheet that Emily Nagoski prints on her website called Turning Off the Offs. It's a worksheet that I use with patients all the time. It's also, though, a worksheet that I use when I go into KU Med, the University of Kansas Health System, and talk to our future providers, our med students, our PT students, our OT students, when I talk to them about sexual health and well-being. And on this worksheet, there are 4 questions that are really beautiful. One is, what is the biggest barrier to our goal? So if you think about yourself as a provider, and if you slide that up to number 3, that's where these great questions are. Thank you for doing that. So what is the biggest obstacle? What is the biggest barrier to our goal? So if you think about yourself and you honestly start to answer this question, then we get to start to move to when and where specifically does that obstacle occur. So if it's something like, I'm afraid I'm not going to have the resources. Okay, so when does that happen? Is it when the patient asks you that question and you weren't expecting it? What can you do to prevent this obstacle? Well, how do you find those resources in your area? And then what specifically can I do to get back to the goal when the obstacle happens? So if a patient asks me about sexual health and well-being, and I freeze, fight, flight, freeze, right? Fight, flight, freeze, fight, flight, freeze. I freeze, and I don't know how to answer that. What am I going to do to get back to that goal once I get back online again? And I can tell you from personal experience, when my husband was going through his cancer treatment, we were trying to have our 2nd child, and I asked the question, how is this treatment going to impact his sexual functioning? And the response that we got was, that's not a variable I can be concerned with. Well, that was a variable I was very concerned with, because we knew whether Mark lived or died, our goal was to have a 2nd child. So my first child had somebody to do life with. Good, bad, ugly. Somebody to do life with. Somebody you can look across the kitchen table and give a little look and start like cry laughing because you know you're both talking about mom and how crazy she is, right, all at 1 second. So regardless of the outcome of cancer, we knew where we needed to be with that. But it was not a variable he could be concerned with. Okay. So anyway, I would just encourage you, we got 35 seconds, I encourage you to really think about like where you all are at personally with this and what you can do to move towards encouraging and supporting the sexual health and well-being of your partners. Okay. One last thing I will note, mental health, sexual health, both very inaccessible in the United States for so many people. They are trying to shift that a little bit with PsyPAC. So since you aren't psychologists, you may not have heard of that. There are nearly 30 states now that are allowing telehealth by psychologists to happen across state lines. So just know that might make some accessibility a little bit better for your patients. So, okay, thank you. Do you have?
We do have one virtual question that I wanted to ask, and it is, what guidance can you give to single women who are beginning to date again about when and how to disclose their breast cancer diagnosis, and how to inform and discuss their altered body, such as mastectomy without reconstruction or reconstruction with obvious scars?
Yes, that is a great question, and it comes up often. It often is context specific. So is that a conversation you're going to have with somebody like when you're in the bar buying a drink? Like, probably not. It can be very relational dependent. So if somebody is leaning in, if you're seeing a lot of vulnerable discussions happening about other topics, that might be a green light that suggests you can also have conversations about this particular vulnerable topic as well. I wish I could give you a really concrete, but it is so dependent upon what's going on in the moment. So.
Thank you. We'll do one more question.
Okay.
I didn't think you saw me. Thank you for that talk. We've been talking about disparities so much all morning. How do you see this in the settings you've seen, in the clinical providers addressing this issue with patients of all races and all socio-demographic stratas, right? I mean, it's just more of a statement. I just think there's so much bias in who and how we talk to in our busy clinics sometimes. Mm-hmm. It's just sad.